Good afternoon, everybody. We're just going to allow a couple of minutes to allow all the registered attendees to come into the webinar. So we'll be with you momentarily. Okay, I think we're going to get started. Good afternoon, everybody. Welcome to the IVI webinar addressing Walking the Talk, How Should Policy Uphold Equity and Value Assessment? I'm Jennifer Bright. I'm the Executive Director of the Innovation and Value Initiative, or IVI. This is the third in a series of webinars on the topic of the intersection between value assessment and equity. And we're very pleased to have three terrific speakers to join us today for this conversation about policy. Go to the next slide, Judy. So IVI operates under a number of principles, and as you'll see, one of them is the notion that value assessment should, as a practice, support health equity. And this has been an ongoing conversation, at least during the 3.5 years of my tenure with IVI. And one of the reasons that we undertook this webinar series was to really explore why is that important? What are the connect points between the concepts and the challenges of health equity and the practice of value assessment? What are the methods? What are some of the novel scientific approaches that are being explored to address these issues? And today's conversation, which is what are the solutions? What are the ways that policy conversations need to support our forward progress in thinking about upholding equity in the course of exploring the value of different treatments, both drugs and devices, and now even digital interventions. So this is our purpose. We've had 2 prior sessions which were very well attended and which had some wonderful exploratory conversation, and I'm looking forward to today's conversation. You can go to the next slide. So I won't read this to you, but Dr. Rick Chapman, who is our Chief Science Officer, and I co-authored a piece earlier in the spring to really focus on why IVI is leaning into improving both the science and the practice of value assessment. And one of our key concerns is that we all acknowledge that the data and the representation of outcomes that are important to patients and families are grossly underrepresented, and they are therefore at risk of hard coding inequities that already exist in our delivery system, in our policy, in our payment structures, in our understanding of how health interventions actually work in real human beings. And for this reason, we continue as an organization to explore this concept of health equity and how value assessment really needs to incorporate those principles and not be a detractor or a further exacerbation of our current inequities in our health system. So that's really our motivation today. Next slide. And I'm joined by three terrific panelists who I feel really bring forward some perspectives of often underrepresented voices in this conversation about value and value assessment. First we have Felicia Woods, who is the Executive Director of the Cancer Policy Institute with the cancer support community, representing obviously the patient and family perspectives that we know are not always well understood or well represented in our data that we use for value assessment. Next, we're going to hear from Jessica Brooks, who is the Executive Director of the Pittsburgh Business Group on Health. And we've heard many times that the employer community is a growing voice in this area, but one that is often put in second chair, perhaps to the perspectives of payers. And thirdly, we are pleased to have Josh Liao from the University of Washington School of Medicine. He's the Director of Value and Systems Science Lab and also the Medical Director for the Payment Strategy Group at UW. And I think that Josh brings both a policy perspective, but also that important clinical delivery perspective that I think is often underrepresented in this conversation about value assessment. So I'd like to have our speakers, we can go back off camera, and I'm going to first call on Felicia. Each of our speakers are going to give just a few remarks, and then we're going to have a conversation. And to those in the audience, please use the chat function or the Q&A function to share any questions that you would like us to weave into our dialogue today. And I also, just before we get started, want to assure everybody that we are recording this webinar and it will be distributed both to registrants and posted on our website. So with that, Felicia, you know, I said in the opening remarks, patient experience, we're still struggling as a field to figure out what's important and how to represent that in the conversation of value. Share with us your remarks, your perspectives on why that's important to upholding equity. What's the intersection from your perspective?
Sure, happy to. I will start off by saying good afternoon. I'm Felicia Woods, the Executive Director of the Cancer Policy Institute at the Cancer Support Community. And so I'll just start by really just talking to you a little bit about what the work that CSC does and how we advocate on behalf of patients. So CSC works to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. And backed by evidence that the best cancer care includes social and emotional support, our services are free of charge to people impacted by cancer. And we deliver a comprehensive menu of personalized and essential services, including support groups, educational workshops, exercise, art, and nutrition classes, and social activities for the entire family. So I said all that to make sure that you understand for us, we're all about treating the whole patient, looking at the psychosocial aspects of not only being diagnosed with cancer, but also how that diagnosis affects a person in their individual and family, as well as societal lives. So at CSC, we often ask the question, so what? In essence, so what is in it for the patient? The patient perspective, from our concern, should be at the center of all decision-making, not just theoretical or performative, but actual. And we focus on a number of pillars in terms of policy and delivery of our services, including, but definitely not limited to, patient education. And that involves individuals impacted by cancer should have access to appropriate evidence-based information necessary for them to make personalized choices regarding their health. Also, the patient experience data. Research and clinical approaches to care must include not only physical, but also psychosocial data that captures and incorporates the full patient experience, across the cancer continuum. So we advocate for patient experience data to be used to inform, analyze, measure, value, and pay for cancer care in the United States. And another pillar that we use is value, and something that we really focus on. In terms of value-based assessment framework, the inclusion of the patient perspective as well as upholding equity is important to CSE. Now, as we know, the US health system is both dense and complex, and often the public doesn't fully understand the extent of the cost drivers within our healthcare system. So in consideration of those complexities, the notion of defining value in the healthcare system is equally as challenging. And of course, that is challenging from the patient perspective. And so depending on the stakeholders at the decision-making table, the definition of value can vary. The CSC firmly believes that individuals impacted by cancer must be at the center of discussions and decisions regarding cancer care value. And so the patient voice is equally as important as any other stakeholder. And I'm not just saying the patient perspective being discussed or talked about in these decisions, but truly the patient perspective should be included and incorporated in the decision-making. So utilizing the patient at the beginning of the discussion or at the forefront of drug development or even device development should be first and foremost. Patients make different determinations regarding what they value throughout their illness, their treatments, and their therapy experience. We believe that value should be individualized, disease dependent, and also evolving. And patients care about different types of outcomes that they consider to be their goals and aspirations or experiences as it relates to their specific diseases. So CSC believes that any value framework must consider those varying preferences, because not only all patients value the same things at the same time. For example, while the financial impact of drugs and devices are clearly important to consider, there are other aspects of value that are critical to include in any comprehensive value assessment. So patients who seek care for different diseases, diagnosed at different stages of progression, with different states of underlying physical, psychosocial, and environmental needs, as well as different life goals and perspectives, must be considered. And given the unique makeup of each individual patient, there's no one size fits all value framework. And so patients make different determinations based on a number of variables that are very much so distinct to them. So when saying all of that, and when you think about the patient perspective and how you incorporate it into the value framework, one thing that we really have to consider when thinking about value-based care and value-based frameworks is also the consideration of the inequities that are pervasive in our healthcare system. Before the COVID-19 pandemic, the need to address disparities for certain populations that have shouldered a disproportionate burden of disease like cancer due to social, environmental, and economic factors was already evident and prevalent. For CSC, the inequitable access to comprehensive, quality, and affordable cancer care is a public health crisis. And it is vital that all people have the opportunity to achieve the best health outcomes, no matter their race, ethnicity, gender, age, sexual orientation, socioeconomic status, or zip code. So when we think about value-based care, which emerged nearly 20 years ago and really was touted to improve healthcare quality while simultaneously containing cost, it unfortunately didn't really impact health disparities. There's a limitation there. Still currently, Black people in particular are more likely than whites to suffer from poor cancer outcomes and higher mortality rates. In addition, the higher prevalence in the Black community for other diseases such as diabetes and heart disease still remains. And moreover, Black patients are more likely to receive low value care. So thinking about the traditional value assessment framework, which focuses on improving overall population health and assuming all health gains are valued in equally, that creates a possible barrier for really developing treatments and innovations and therapies for patients from disadvantaged communities. And so these traditional frameworks do not consider the importance or impact of achieving equity and health outcomes. So for value-based healthcare and frameworks to really reduce disparities and inequities, there must be a foundation and understanding of structural racism and systemic issues that are prevalent in our healthcare system. And we need to determine meaningful ways to address these issues in an effort to create equity and better health outcomes for all patients. As a result of the pandemic, we've seen a better light in understanding and the need for inclusion of data collection on a number of areas, including race and ethnicity, but also looking at geographic locations, as well as the focus on age, which is very prevalent. We need to understand how different diseases affect people in different ways and what the individual just considers to be of value to them. For cancer, does that person want to continue to work even though they're receiving active cancer treatments? That's something of value to them that should be considered and assessed within a framework. So essentially, value assessment changes and evolves, as well as new technologies, treatments, and options. And the same with policies and systems have evolved, but also the lives and personal situations of patients change too. And patients can be best understood by being able to express their personal preferences, as they can give the most accuracy to what's important to them. CSC, along with other patient advocacy organizations, believe that the patient and caregivers' personal aspirations, quality of life, out-of-pocket costs, hope, convenience, and certainty of prognosis, as well as patient engagement, must be weaved throughout the development of a value assessment framework. And that's truly the best way that we can really start to understand and unpack the inequities within our system, is by being more patient-centered and patient-focused to drive down some of the disparities that we've seen in our system throughout. So I thank you for the opportunity to be here, and I welcome any questions as they come.
Felicia, thank you so much for starting us off with such a great framing of why it's important and from the patient perspective. I know earlier today I was reading a post from the Robert Wood Johnson Foundation, and they really raised this question of equity and representation in research and novel methods and data. And these are all themes that you hit on in your remarks. So I look forward to exploring that in our discussion. Jessica, let me turn to you. I said at the front that employers are kind of a growing voice. I know from your perspective and your constituents' perspective, you should have always been in the front seat. But I wonder if you could share with us some of your perspectives, and particularly where you think the employer community sees a place to start. Where are some of the policy priorities that we need to really dig into in order to address equity?
Sure. Well, thank you, Jennifer, for this opportunity. It's been a pleasure getting to know you and to be a part of these discussions more fervently, I guess, and focused since COVID-19. However, for me in my career, this has been a part of my career and discussions, and honestly, personal life for me for many, many years. And I share oftentimes how personal health equity is, and oftentimes in these settings, we speak to it in an academic way. But when you hear 2 times, 6 times, 4 times, 3 times, oftentimes that means the likelihood of someone who looks like me more likely to die or have adverse outcomes that many times are preventable, and has lack of consideration or design as a result. There are major inequities. And so, I love to bring in the personal component of this, because I think ultimately that's what's going to make the difference in how we move forward in policy and in value and approach and advocacy as we activate employers. Employers for many years, I've been leading the Pittsburgh Business Group on Health, which is a nonprofit healthcare coalition based in Western Pennsylvania. We have employers up from either headquartered here or have a significant portion of their populations who reside in Western PA. However, many of them have employees spread all over the country. So within our membership, there's about 2 million lives represented, over $5 billion in healthcare spend just with our coalition alone. Employers play a major role as purchasers in the healthcare system and really require value. How we define that is where we have missed the mark, I believe, and where we're evolving to include equity. Value included cost and included quality, but in that quality definition, equity really hasn't been centered, and that I believe is changing and has changed for many of our members and many employers from across the country who are now activated around the issue of equity and racism and inclusion and cultural competency. And I have to mention those words because honestly, without the events that happened in 2020 around the murder of George Floyd, employers really hadn't stepped up saying that they were committing to address racism or inequity. And we saw major billion-dollar commitments from our banks, including one of our banks right here in Pittsburgh, PNC Bank. We've seen from Google, we've heard from JP Morgan, many large organizations and many small and mid-sized organizations saying we have to do something, we pledge to do something. And where we've focused is how do we connect the dots between this now great commitment, long overdue commitment and focus at the highest levels of leadership with the health equity issues that we have and health equity responsibility that we have, and how do we help employers align their strong commitment to serving the community and realizing that the product that they provide to their employees in the form of healthcare benefits often opens a gateway to trauma at times or adverse outcomes. And they're paying for really bad care sometimes. They're paying for unintentional mishaps due to lack of cultural competency. And so, we're on this journey of activating employers from one, understanding their role, that they have an actual role to play. We believe that transparency in their data is important. One of the things that we've done over the last year is work with our data vendor, to bring visibility to race and ethnicity as we were looking at our COVID-19 dashboards and what was impacting employers, or how did they identify higher risk populations within their workforce or their plans. And oftentimes that was based on CDC guidelines and by condition: hypertension, asthma, cancer, other chronic diabetes, other obesity, mental health claims. But what we didn't see was the intersection of race and ethnicity and how that impacted or should impact their decision-making to bring people back to work or to account for them in their policy changes. So that's one thing that we have to make sure as we develop policy, that we have a level of transparency in the data. We also need cultural competency by way of diversity in the decision-making and design of policies. That's critical. That when I surveyed employers, many of them said that they believed lack of representation in clinical and administration within our healthcare delivery system was a big reason why there is mistreatment, as well as the level of disparities that exist in underrepresented populations. And so with the business community recognizing representation matters, that is a conversation, dialogue, I believe we should be having more with the business community and the healthcare system and delivery system and policymakers around what does the impact of representation really have, and how do we account for that and make progress in those spaces. We also heard from employers that they need data, that they understand that they need quantitative data. They'd like to see what that looks like in their claims, but they're scared of that. They're scared of that access. They also said, where are the stories going? Where's the qualitative data? They're not coming back to the business community. employees like myself I'm not going back to my board of directors, for example, or when I worked within an organization in middle management, I didn't go to my boss and say, this is how I was treated during my birthing experience. Those stories oftentimes don't come back to the business community, and they oftentimes honestly don't go back in a meaningful way to the healthcare health plans that employers typically work more closely with. So how do we begin to capture those stories qualitatively in an authentic way, but in a way that will help us understand the experiences and then manage and account for that and be responsible with those experiences and that information? So I think that's a huge gap, and that's one that we've been talking about quite a bit is this, what is qualitative data? How do you capture that? How do you leverage the populations? How do you now hold your vendors accountable for an equitable strategy, from chronic disease management vendors to your health systems, to your health plans, and even the new technology vendors that are coming up with new digital therapeutics and digital solutions? Are they really designed to help close the gap, or is there bias embedded in those designs? How do we identify that sooner than later so that we're not procuring solutions that ultimately may do more harm to some of our population? So I'm looking forward to the discussion. Hopefully that answered your question, Jennifer, and I'm excited to be at the table here today.
Jessica, thank you. I think, this is a big topic, and I will say with pride that IVI doesn't shy away from tackling the big elephant in the room. So we knew this was going to be a wide-ranging conversation, but I think you bring such important insights, and particularly it's good to hear that the employer community sees that one of the big problems is the representation and the transparency of data. I think writ large, the healthcare system is working in a lot of different silos. And I think from our prior conversation, one of the things that needs to change is that we have to start looking across, or we're going to miss the forest for the trees, as you pointed out. Josh, let me invite you to come on camera. And I will say, just by way of lead in, the reason I picked up the phone and called you was when I read the first line of your article last month, where it said intention matters in health policy. And being a policy wonk as I am, it grabbed my attention immediately. And then your article went on to talk about the fact that we've been moving as a national, in the national conversation towards value-based healthcare for a while now. But your article said something that totally hit the nail on the head from where IVI comes at it. And that is, we're moving in that direction, but we're not translating that into actual value that meets the needs of a pretty diverse population. And this is a problem. And so that's why I called you and started badgering you to join us for this conversation. So maybe you could share a little bit about the article, because I think the other thing that attracted me to talking with you was that you had some very specific policy solutions or directions that we need to go. And I think one of our goals with this conversation today is to really unpack, where do we start? This is a big conversation, but how do we get off the dime and just stop diagnosing the problem and actually do something? So Josh, share your thoughts there.
Well, thanks, Jennifer. And you didn't have to badger me too much. I'm really honored to be here with everybody, in particular, Felicia and Jessica. So thanks for having me. As I approach this question of how should policy uphold equity in value assessment, it's a big topic. I think I hope what we'll talk about in discussion is these are both and, like all in, not either or solutions and areas we need to work in. I approach this question from what I call a three-pronged perspective. First, I'm a clinician. I take care of patients in an urban setting. My patients come from diverse backgrounds and communities. It's really a relevant thing to me, and I'm an internal medicine physician. So I'm fortunate to think about patients from a holistic perspective, kind of across conditions and care settings, et cetera. So that's the first. The second is that I am fortunate to be a scholar at the University of Washington, where I evaluate the impact, intended and unintended, of different public policies with a focus on payment and value. And then the third is I'm a health system leader, and in that capacity work to understand with other leaders, how do we translate that public policy, and in particular payment, into practice and into the care of patients. And so I kind of braid those together as I think about this question. And there are a few principles that this creates for me that I use as a starting point. And the first is, as you mentioned, Jennifer, that intention to me matters in health policy. And the reason is that we will talk, I hope, far-ranging and in-depth and thoughtfully about implementation of policy. But intention always precedes implementation. And I think we should recognize that going forward. The second is that while payment is and should not be the only motivator, the reality is it is nonetheless a powerful one. And so I think worthy of inclusion in this conversation. The third is that I think putting those together, intention should really drive policy related to value and perhaps more specifically, value-based payment. And fourth is when I think about policy, because of my kind of simultaneous roles, we can think about policy in the public sense, right? What gets written into law, what gets legislated, but also what I call private policy, the things that advocacy groups, purchasers, payers, insurers, CMOs, CEOs, clinic directors, these people are what I call privacy policymakers that have to implement all of that and actually lead it and execute it. And so those are principles that I kind of come from based on my perspective. So returning to your question, how should policy uphold equity and value assessment? This is by no means comprehensive, but as a start, I think there are a number of ways, and I think maybe at least three that I see. The first, as I mentioned, is to really set an intention to use value-based policy, payment and otherwise, to advance health equity. And I probably don't need to tell this group this, but I think traditionally we've thought of value really with respect to quality and expenditure and spending. And that has been valuable in some ways, but really nowhere coded into policy is a direct focus on equity. And so I think so long as those issues of disparities and equity and representation remain unintended consequences, I think we in the health community will be in a somewhat reactionary posture. We'll be monitoring and responding to them. But I think a better way is to, again, recognize that intention precedes that implementation. If we set an intention to address disparities, I think our policy will look different and our value assessment will look different. I think leading from that point, second, I think, is to incorporate equity directly into definitions of value. So not to get into the technicalities of it, but I do think incorporating equity directly as people think, as how do I assess value? How do I evaluate it qualitatively from different perspectives? I think it has to be forefront. And I think there's opportunity there. The third is to convene a multi-stakeholder group to guide all the things I just described. And that's a word that's often bantered around, but I mean it. And we heard it from Felicia and Jessica, but I think there has to be the voice of patients in their communities. There has to be purchasers. I include employers and insurers in that. I think clinicians and their organizations need to be there. Other groups. We really do need diverse perspectives to guide the kind of substantive changes I think we're talking about in bringing equity into value assessment, programs, policies, and methods. And so what would this group do? Again, not an exhaustive list, but I could identify a few things. The first would be to help set bold but reasonable goals for doing this work. You know, suffice it to say, goals really help drive behavior. And I think together with not having equity in the definitions of value, we also historically haven't had goals around advancing equity through things like value assessment or value-based payment. So I would love to see goals there, and this group could help us do that. The second would be to adapt existing elements, data, technology, infrastructure, to develop the things that we need to make these changes. You know, no payment systems, no delivery systems exist in a vacuum. And we have lots of things that exist today. And so the question is, how do we adapt or evolve them forward to the purposes that we're talking about? It's another work area. Another area may be to kind of implement changes and harmonizing kind of the policy and the practice. And I could envision things like setting up implementation roadmaps, really understanding, you know, X or Y might be a nice policy concept, but when you try to bring it really into the community, into the clinical setting, it's not that easy sometimes. So how do we implement all these things that we'd like to see happen? And then the last thing I could see this group helping do is support evaluations. You know, it's an old and sometimes overused adage, but you know, we really do change what we monitor and we measure and we motivate. And so regardless of what kinds of data we use, regardless of how we do the assessments, I do think it's important to be able to go forward by saying, this thing that we did worked, this thing we didn't do, this thing we did not work, and et cetera. So I think the evaluations are really important here. So of course, these things I've listed here are just a start, right? And I want to say from the get-go here that no approach to payment or value-based assessment is immune, right, to unintended consequences. I acknowledge that. I think from my perspective, payment is an important key point, but it's only one, right, of many areas that we need change in. I think the other panelists have highlighted really important ones. But nonetheless, I do think in closing here that payment is a powerful motivator. Intentional changes can harness it into a powerful solution for addressing inequities. And I think that we in the healthcare community really should undertake this work without delay. So with that, I will stop and pass it back to you, Jennifer. I appreciate the chance to give a few comments here.
Thanks, Josh. Let me invite Jessica and Felicia back on camera as well. We have a couple questions. I want to urge our audience to begin typing questions in the Q&A or in chat, whichever suits you, and we'll be monitoring them. Let me ask a question that's been burning. I think all of your remarks were perfect and raised all the issues that have been buzzing around in my head. And as I said at the beginning, on a daily basis, I'm reading news articles and journal publications and blogs where organizations are beginning to think in the same direction. So I referenced Robert Wood Johnson Foundation talking about, setting metrics for research, like what are you funding? Is it representative? Is it including patient perspectives? Is it multi-stakeholder? We need to start to lean into that, and if we're going to improve the data ecology, for example. I saw an article this morning about using the national vital signs as a way of measuring equity. I'm sure it just crossed my eyes maybe 20 minutes before this session, so I doubt you have seen it, but the point is that we're all leaning into these questions of how do we measure this? How do we leverage the data we already have? And then how do we improve the delivery of care? How do we understand the cultural competence from the cultural competence angle? Let me add one more to that pile, which is we've seen that on the Hill, the congressional consideration of this concept of value and the notion that what we need is a major entity that's going to look at value and declare intervention, device, digital therapy as being value for the cost that it's proposed. Senator Wyden and others are pushing notions of how do we adopt ex-US strategies. How do we create an entity that can be an arbiter of these very complicated issues? What would you say to Senator Wyden or to others on the Senate Finance Committee about this issue of equity? And some of the issues you raise, I think, are not intentional, not top of mind in the conversations that are currently going on the Hill. So how do we incentivize a focus on these issues that you've all raised, even now as there are policy debates happening that I don't necessarily think incorporate some of the points that you've raised? Any thoughts? I know that was a big one.
I'm happy to maybe lead off here and just say that I think from my perspective, lots of public policy has focused on how do we get the biggest proverbial bang for our buck? How do we get the biggest change for as many people as possible? I can't argue the value of that. However, I do think there's another thing. How even is the bang for the buck? So how do different communities from different backgrounds, socioeconomic, race, ethnicity, sexual orientation, et cetera, how we define it multifaceted, how even is the benefit? And I think that's something that I really think could be put more front and center. So that we're not just looking for the biggest effect size, the biggest savings, the biggest quality bump, but also how even and distributed that is. And the other thing I'll say here is that I think there have been recent evaluations, at least from the payment perspective, that these programs, quote, don't work, or they save money or they don't. And I think I would love to see the conversation go to more texture there. And by that, I mean, maybe in the average, in the grand sense, it, quote, didn't lead to some outcome, but did certain subgroups, did it help? What did it do to disparities? Those are questions that I don't think are conceptual. I think we can put those in front of and have conversations with decision makers on those. And so that would be one that I had.
Yeah, I think-
Felicia, any thoughts there?
Sure. So I actually am going to move the needle away from just looking at the federal impact of what can be done. I think that, of course, we can do more at the agency level with HHS and FDA and all the various components of our healthcare system. But I really think we need to look at how can we focus on health equity and value at a community-based level. Honestly, many of the patients that CSC serves and other patient advocacy groups serve is where we meet the patient where they are. And in the equity space, when it comes to policymakers, I don't know how many of them are going to the various communities to hear what it's like trying to get access to treatment at a local cancer center or through a local provider, and how we can incorporate those aspects into the federal decision making. When I first started working on the Hill, I worked for a member of Congress who specifically talked about local politics and how that is influential in your day-to-day life. So how can we work with our local and state legislatures on this question of value? And then it moves its way up to the federal aspect. I firmly believe that there should be some type of intersection between the two, more so than us starting off on the federal level. How can we elevate what's already being done locally and community-wide in these disadvantaged or underserved communities, what they're doing best, and elevate those best practices at a federal level? I know that's not necessarily what Senator Wyden would probably agree to, but this is just my thoughts on how we can move the needle in equity.
Thanks. And Jessica, sorry to overshoot you.
No,
No
no,
thought there.
I totally agree. I was actually going to talk about the strategy is how do we elevate the experiences to that level and to be in the room. I mean, you can only design from what you know and what you're informed of. And we need I'm not sure if it's an entity per se, but maybe it's the system of how do you go from community, local to state to government, a mechanism to elevate those experiences to be considered in design and policy making. That has to be the mandate, that has to be intentional. We do know from there are accountability institutions right now. NCQA has equity measures. We have, HEDIS measures. We have CMS star ratings that do impact payment today. Those entities influence models today. We, unfortunately, on the commercial side, don't always benefit immediately because we don't have that oversight in the business community at the same level, but we do have the insurance commissioner, right? For fully insured plans in our states. We do have the Department of Insurance. We have, HHS and Department of Health in our states. So there has to be a pressure, I believe, applied to our state legislatures and representatives and government officials with the community partnership to align and elevate those experiences. That's the secret. I mean, honestly, if you hear the stories and you understand how it manifests in practice, then you can come up with a solution.
So we have a question that probably builds on what you just said, Jessica, from an attendee, and they say, how are you, and I'm reading verbatim, how are you pushing back on the insurance industry, especially in the very competitive and sometimes crazy Pittsburgh insurance market? I fear that many of the current benefit designs are discriminatory to certain populations, especially in cancer. I know this is something that came up during our prep call about benefit design being an area for focus. Can you speak to that a little bit and what your group is leaning in on there?
Sure, I definitely can. We leverage an assessment through the National Alliance called Evaluate that we're encouraging across the country for employers to mandate that their health plans participate in. for the first time this year, Evaluate is incorporating more questions that for the health plans to answer on what are their strategies and priorities when it comes to health equity. I believe if for employers, their contracting strategies have to be the way, is a core focus, not the only way, but it is a key priority. And one of the tools that we traditionally use in procurement and accountability through the RFP process and other types of evaluation processes to hold accountable. We have to begin to ask the questions and expect those questions to be answered by health plans and other vendors. It's not only health plans, other vendors that sell services to us to address population health management. There are also entities, the Preventative Task Force, that provides guidelines. And these guidelines, then the health plans use, then that passes down to employers. And an example, around, they give guidelines around cancer screenings, they give guidelines around mammograms. We know that African-American women, although develop breast cancer slightly less, die 2.2 times, the rate, and get the breast cancer typically earlier in age. Yet these entities that we get guidance from, they don't provide mammograms or cover them at no cost, or they'll cost till age 40. So we have this intellectual insight as to that the death rates that people get this of African-American descent get breast cancer earlier, but we're still not going to cover a mammogram until 40. So those are the type of plan design changes, conversations we have to have with our health plans, is questioning why. If we know this information, then why are we not providing better plan designs that are more inclusive? I 100% agree that that our plan designs oftentimes, whether it's payment barriers to access to care, or it's these access to services at the appropriate times. Colon cancer is another good example of that, where we are not eliminating the barriers to colon cancer screenings, fecal tests, making it easier to identify colon cancer, and people are dying at disparate rates as a result of that. That's preventable. So there's great opportunity there. And I also think employers have to have direct conversations with hospital CEOs and executives, and almost move the health plan to the side at times and develop direct relationships. I'm not necessarily direct contracting, but they have to have a face and set the expectation even at the provider level.
So I was just thinking that, and Josh, perhaps you have a perspective coming from a health system perspective on the same question. You talked about the fact that payment is a lever to incentivize a focus on equity. So, hearing Jessica's remarks, how do you respond or amplify from a perspective of a health system?
Yeah, I mean, I think that as I'm processing all these really great comments, and I think this is the first instance, as I mentioned, of the kind of the both and. I think if we stay from the position of at a high level, federal or another one, and we just kind of throw policy down, I don't think that's a way forward. I think the other issue is that communities, health systems, right, are so varied. And so as we bring those stories up, where are the commonalities and where are the variations? And I actually don't think there's like a menu of 4 things that we say, okay, this is what we'll do to benefit design or payment or delivery or implementation of guidelines, and we're done. I think we may come to a place where there's a collection of things that we say these are common across and we should apply them in a broad way. But then there's a level where we do need that texture, that local context. And actually too broad of policy actually can be, it's too blunt an instrument, actually. And so that from a broad level, that's how I think about it. That's what I see in my own work. We cover a large area. We, again, as I mentioned, we have a diverse, I'll call them patient populations, plural. And one of the lessons that I take away from that and putting it together with my policy work is really that any policy that doesn't consider what's happening locally as a problem, any policy that takes one local circumstance and then spreads it to everywhere else is also potentially problematic. And I think we need to find a different way to do that, which is, I think, part of the work that we're talking about.
Yeah, that's great. That leads me to really thinking about value assessment, which is something at IVI we eat, breathe, sleep, whatever. And that is in the context of value assessment, really trying to understand the relative value of a therapy or a sequence of treatment. What are the important components that we need to improve the data flow? What needs to be represented in this conceptualization or framework, to use your word, Felicia, of value that we're currently not getting? I think this is something we spend a lot of time exploring at IVI, but I don't know that at a broad level, we've come to an agreement about what the priorities are. Any thoughts? Oh, that's wide open.
Sure, I'll say for, the patient perspective, the priority is really what's important to the patient, the one who is being treated for the specific disease or illness, and looking at their perspective throughout the in the cancer realm, throughout the cancer continuum, and asking them from beginning to end with their I think with our oncologists, having that participation in the decision making when it comes to their treatment plan. Also, as I mentioned in my opening remarks, when you think about a person who's newly diagnosed, do they still want to work? Is that important to them? The quality of life aspects related to the value assessment framework has to be incorporated. In addition to thinking about also financial toxicity, but there are other aspects of a patient that has to be weaved in. A lot of patients are coming in, they're working full-time jobs, they are caregivers themselves, they have families that they have to tend to via childcare and other issues. Maybe they're facing transportation issues as well. So when you think about that whole person, that whole patient, that's where the value comes in, and having that assessment of them individually, making sure that whatever framework comes about, I'm not saying we need to have 1,000 different frameworks that fit 1,000 different people, but how can we take a framework and tweak it so that it works for that individual and their individualized, from the cancer perspective, their individualized cancer, because not all cancers are the same. So thinking that through is one important way that we can really keep that patient-centeredness of the value framework. And one thing that I mentioned earlier was, of course, there are discussions about what's important to the patient that all decision makers have. But if the patients aren't represented at that table, to have that voice at the decision-making table, then you're actually losing out their true perspective, because they can give you their individualized or community perspective on what is important to them.
Thanks for that. Josh, or Jessica?
I'll say a few quick things. I think I wholly agree with what Felicia said. The thing that I really grapple with, I don't have an answer for, but I grapple with is that there's so many ways to think about how to group people and then how to ungroup them. And cancer, other diagnoses, kidney disease, heart disease, those are one way to do it, really important ones. Community membership is another one, where they get care, and they're not mutually exclusive, but I think Felicia put it well. We can't die by 1,000 paper cuts. We can't have, a million frameworks. We can't have one. And how do we find that balance? I think that's the tough work, right? So that's the tough work. I think it's the work we need to do. And I think that all of us probably agree that in that work, certain frameworks will float to the top as more pressing ones. But the other side of that coin is there'll be ones we should probably abandon or set aside, right, as ones that we don't need. And are we ready to do both of those things? I think that's the only way forward here as we think about assessment.
Wonderfully put. Actually, I know you said you're grappling with it, but I think you hit it right on the head. And we're trying to all thread that needle. Let me go to an audience question. Let's see. The U.S. Let me read this because it's long. The U.S. healthcare system is increasingly becoming a for-profit enterprise. When organizations that provide treatment are motivated by having the most efficient payment system to deliver financial value to their shareholders. How do we create policies that ensure value assessment focuses on treatment outcomes that are important to patients and eliminate or decrease inequities if it means less profit for these organizations? So this is another challenge that we confront in really making meaningful or intentional, Josh, change, is that we have misaligned incentives. Any thoughts there about the motivation? Is that, do we come back to the notion that there has to be a collective voice, that this is important enough, we need to move, even if it makes established incentives uncomfortable suddenly? Jessica, maybe I'll start with you there.
Well, will you let me know if I have the question right? So I'm thinking about just things that we're working on or looking at. So there's an organization called Get the Medication Right Institute, and they're advocating for the pharmacist to be the actual prescriber, the physician and the patient all being at the table, and how important that is to manage right prescribing, right dosaging, coordination of multiple specialists or doctors, depending on the complexity of the patient, and having the patient voice right there at the table. Those are models that I think we as purchasers can expect and create. We can certainly, identify and partner, directly with certain physician groups or doctors, but to be able to get that more widely adopted as a best practice, for example, are ways that I think we can address poor incentives. We do know, or many of us know around, when dialysis clinics and the locations of them and, the likelihood of, somehow in certain communities, we have they're full when there could have been preventative therapies that, you never even had to get to the dialysis clinic, right? There were therapies that delayed care that happened, I believe intentionally, to ultimately feed a poor incentivized system. And those are things that I think we have to create awareness. There needs to be a public service announcement campaign to the public around these practices to help them understand or identify or ask the right questions. We have to have an empowered patient group, and unfortunately, fortunately, we have groups like Felicia leads and around cancer and by condition, but many of us are left out until we need it. And we're not in those groups until we need it, and that's too late. We need a preventative public component to empower consumers as decision makers in these things. We know that transplants for liver, Blacks are more likely to die from liver disease due to being denied more aggressive treatments. We know that in the drug space, that treatments have been denied earlier, not because you happen to have the wrong genetics and your demographic is more likely to die. A lot of these things, 60% of the maternal deaths in this country are preventable. So, I think we don't focus enough on the actual physicians, the care delivery. We often address payment, but I don't want to pay for bad care. I don't want to pay to be pushed into a system and a model that's designed to cut off my limb versus preventing my diabetes from progressing to that point anyway. And we are paying for that. And so there has to be something beyond just starting at the payment. We have to start at quality, and then we have to incorporate cultural competency into those things. I believe mandates on not just, softball, anti-bias, microaggression training, true anti-racism training should be mandated. And right now it's just left up. If you're a public nonprofit entity, you still have the ability to just decide how you're going to train, who you're going to train, who's getting trained in your facilities. And I don't think that should be left up to just, your decision making. I mean, at some point we have to have a model that says this is a necessary type of development, because representation is going to happen over time, and representation enough to educate in the system that exists today doesn't mean it's going to solve the problem. There's going to be doctors that look like me that still treat me in a way that they've been taught that's not as adverse to the outcomes that are desired. So we have to do something beyond, in addition to representation around training, that I think plays a role here as well.
Josh, any thoughts there? Because I think, Jessica definitely talked about the notion that where do we start? Which part of the balloon do we squeeze on? There's a heavy emphasis right now on the payment aspect of it, but one could argue that that's too far down the chain. I think what you're saying, Jessica, is we need to look further earlier in the entire enterprise, as opposed to worrying about what happens at reimbursement, because at that point, everything's happened. You've missed the diagnosis, or you've delivered poor care, or you've denied care, whatever. What are your thoughts there? And because your article focused a lot on the payment side. So any reactions?
Yeah, a few. First, I think my two thoughts here. The first is I think my focus on payment is really part of what I'll call a portfolio approach about doing this. I knew I was going to say this a few times today. It's like a both and or multiple and type of thing. I think about it as kind of part of the life cycle, meaning I fully agree with Jessica as a clinician, thinking about the ways I've been taught and then reflecting on how I teach others, that come and train under me, work with clinical team members. Those types of things, reaching up as proximal as you want, are really important. But between the time of like doing that and then seeing it in patients' care can be kind of long. That's what I mean by life cycle. Payments happening as we're having this session right now. I mean, people are getting paid right now as it happens. And so to me, it's much closer to what happens tomorrow, the next week. And so when I say both and, I mean, we should move those both forward, but we should probably also acknowledge we won't see the benefits of certain ones of these for days versus weeks, months, years, maybe. And I think that will kind of set expectations. I'm going to go back to the question a little bit. I think oftentimes we think about it as incentives and motivation, and they kind of become one thing. But one of the things I really want to highlight that I hope definitely Felicia and Jessica have brought to the surface is that there are a lot of things that we should do that don't relate to money, right? And that they're non-financial motivations that we really need to focus on. And so when we think about the incentives, I think a better way of saying it is our motivators, and a payment can be a motivator, but there are other things: professionalism, equity, other ethics of care. I mean, there's a list of things that, as a clinician, I think about what's right for the patient. And speaking for general internists, we don't sit there thinking, okay, if I do this, I'm going to get this much money. That's not the calculus when we're like counseling someone on depression or working with them on their diabetes, et cetera. So how do we capture that in value assessment and in policy? I think is really important. And just to put a fine point on that, I would hope that the conversation about what drives healthcare moves beyond the payment, although that is a key component.
Yep. Felicia, any thoughts before I
guide
us
definitely.
into the? Yep.
I think, well, Jessica and Josh have definitely hit the nail on the head here. And I looked at the end of that question, and it says, how do we create policies that ensure value assessment that focuses on treatment outcomes, and if it means less profit for the organization? But I guess going back to Josh's points about the little policymakers, the people who head up organizations and head up entities that create internal policies within their organizations, does that necessarily mean, if you're coming at it from a value-based assessment that's focusing on outcomes that will eliminate inequities, will that necessarily mean that there will be less profit? Could it actually mean that your service delivery is a little bit better and that you could create or benefit and have a higher profit? You just never know until you start implementing, until that intention goes towards walking the talk that we have all been expressing for a long time about doing better when it comes to addressing inequities. So it's honestly a challenge for those policymakers within organizations to really take up the helm right now to focus on the inequities that are driving our system and trying to figure out ways where we can reduce those to make it a better place for our patients to truly say, because reputation matters in a community. A doctor's reputation matters, a system's reputation. I can think right now, I'm originally from Memphis, and I can tell you right now, the hospitals that if I was to go to my grandmother or somebody else, they'll say, oh, don't go there because the healthcare delivery isn't great, or they don't treat Black people well there. If you can have a reputation in the community that says, oh, you know what, they listened to me, that doctor heard me, I think you'll get more bang for your buck if you really come to a consensus with your shareholders and board of directors and everyone in that organization to focus more on that perspective of reducing inequities in the system.
Can I just respond to that quickly? Is that okay, Jennifer?
Yeah,
I would just
absolutely.
I would underline that. I want to just take that point forward, at least in my perspective, is that, you know, our health system has a really important role in what people often call safety net and providing care to groups that otherwise would have a hard time accessing care. I would love for what Felicia said to be true. For those organizations that do that and can't wait for all the market forces and invisible hands to play themselves out, you know, I do think going back to the topic of this session about policy, it happened already, right? There are mechanisms by which those organizations get financial assistance, et cetera, but I think more work needs to be done there for those quote safety net providers and organizations and the patients they take care of. So I just to round it out one more time, I think it's a both and. I would love for the market forces to drive us there, but I think in the interim, we need policy to say these people are doing things the right way. They're doing it even if the financials don't work out, and how do we support them in that?
So that leads me to my last question, and we may do a lightning round if we have time, but we've talked about your organizations and the communities, the sectors that you represent writ large. We've talked about an alphabet soup of organizations that have expressed concern, care, and even financial investment in some of these questions. So who leads? I'd like to think, you know, I think one of the things that IVI wants to do with this series is to think about how do we lead? How do we lead in the direction of new methods? How do we lead the conversation about value in a direction that supports and moves the needle on a lot of the themes that you've raised? But we're 1 in 1,000 organizations. So is there a clear leadership role here, or are we going back to something Josh said in your remarks, which is we've got to start together? Any thoughts? And if you want to, you know, direct message to some agency, now's your opportunity. So go, Jessica.
Yeah, that's honestly, Jennifer, that's hard. In our space, you know, as coalitions, we say employers, wake up, activate, you're paying the money. Like without your financial contribution to the system, whether it's working for you or not, it would not exist really. You know, the government funding would not be enough. We need employer purchasers to activate. I'm not saying that they're going to lead. It's not their industry. It's not their expertise. Fortunately or unfortunately, every business leader has to be in the business of health and public population health, because until you have don't have humans, which hopefully we'll maintain that, you have to be in population health. Your business relies on the health of the people. I do believe, though, without patients being able to be organized in some kind of way, that pressure won't stay on employers, that employers won't keep that pressure on plans and systems, you know, so we do have to have a strong activated patient base. And one of the things that I emphasize is that cannot be only what you deem as most vulnerable, or you know, that the population has to be on Medicaid or a certain health plan or covered by the ACA. No, we're leaving over 170 million people out of that equation, who are covered by employers, commercial insurance, if we do it by payer mix. Payer mix, one of the things Josh mentioned is, how are we categorizing this, and what categories shouldn't be on the table anymore? That, to me, is old school. Like, we cannot do, you know, divide the line by payer mix alone, because there are a lot of other factors that, in my experience, may be equal to somebody with a different pay, you know, color card on their insurance card. That is not adequate. And so researchers, I believe, have a responsibility to look at things very different, and play a leadership role in this as well, and provide best practices that employers do adopt, that health plans do adopt, that is inclusive on the onset. And so I didn't give you maybe the answer you wanted, but yes, there's a lot of roles for leadership, room for leadership in this space.
Felicia, and maybe I'll give Josh the last word. Felicia?
Sure, I agree with Jessica. There are a lot of roles for leadership here. The patients, of course, should be at the table and should be part of the leadership as well, but we can't do this in a siloed way. I think for a number of decades, our healthcare system has been siloed. We've all been separated in trying to lead the charge in addressing health inequities, but we have to do it in a partnership and be willing to be vulnerable and be willing to be uncomfortable in order to have the discussions that are needed to help the communities that we're all, in essence, trying to serve and create better health outcomes for. So it has to be patient groups at the table, it has to be payers, it has to be physicians, also, researchers. Everyone needs to be there. This is going to be a large table, but we're serving a large community. And I'm hopeful that as we continue to have dialogues like this, where a variety of groups are represented, that we're able to break those barriers and break those silos down to have continued thoughtful conversations that will, in essence, help the patients that we're all trying to serve.
Right. Josh,
just maybe
yeah, go.
Yeah, just a few things to maybe add to those really great comments. The first is that I think there's a difference to me between whose voices and whose perspectives need to be elevated and who needs to be there together. So I would say we need to start together. That doesn't mean every perspective needs to be equally loud or needs to be equally weighted. I'll just say that. And I think part of that is historical, right? That when we think about value and value assessment for 10, 20 years, we've considered certain stakeholders' voices very clearly, and we've considered others not at all, and some just a little bit. And I think a rebalancing has to happen, but I think everyone needs to be at that proverbial table. I don't see any other way in this interconnected thing we call healthcare, and even public health beyond that we go forward. So that's how I'd answer that. I mean, the other thing is, I think within that group, though, it doesn't mean it's all spread evenly, right? I'm looking at you, you're looking at me. I think it goes back to that point of, if we're talking about things we can do in payment tomorrow or next month versus things we can do in training, which might take a longer period of time, or regulatory or this or that there can be subgroups within that bigger coalition that say, hey, we're responsible for this, where maybe another group in that area of work is informed or consulted on that, right? And then in another kind of work stream, it flips. And I'd love to see a little more focus in that way, because I think sometimes when we think about these coalitions and these groups, you think, okay, great, everyone's going to talk about the values and the morals behind it, and that'll be it. I do think we can get work done, and it means to kind of drill down on subgroups within that broader coalition.
All great. So we've solved the world's problems today. I want to thank all three of you for a wide-ranging and really authentic conversation about this. It is not for the faint of heart, as we know. And I think you've all brought forward some really thought-provoking ideas and concepts to help drive our thinking. I can speak for IVI. This is exactly what we've been thinking about and how we drive our conversations about methods, about patient involvement, about prioritizing patient perspectives and experience that need to be brought into the conversation of value. This is all front and center for us. So I want to thank you very much for your time. And I also want to thank our audience, many of whom are IVI members and supporters. So thank you for participating. I will say that watch IVI space. We are continuing to lean into this work, both in our efforts to develop a new open source model related to major depressive disorder. We're doing so through partnership with organizations like all of yours. And we are working towards a methods focused summit this fall that really focuses on what are the important aspects and elements of patient experience? How do we measure it? How do we improve the data ecology in a way that supports not just the patient perspective being embedded in value assessment, but we do so with equity in mind. So I look forward to sharing more about that. And if any of you who are participating today would like more information about that or to engage with us on this journey, please reach out to myself or Rick or one of our colleagues. So Josh and Jessica and Felicia, thank you so much for your time today and your wonderful contributions to this webinar. And good afternoon to everybody.
Thank you.
Thanks for having me.
Thank you.